Thank you very much. And to follow on the subject of DVT, so I will talk about is there an evidence to help us to do venous interventions in general? I have nothing to disclose. These are the goals of the outline goals of therapy. What are the major randomized studies and which therapy? Generally, when we treat DVT, we have one of three in mind: to relieve the symptoms, or reduce the chance of post-thrombotic syndrome. And we tend to say we are trying to preserve the functions of the valves. As we know, thrombosis is a mixture of three factors, and we need to watch that there are few of them, such as the vessel wall, we might not change with the treatment. If it originates DVT as a problem with the vessel, sometimes hypercoagulability and stasis. So which one of those are really reversible? So this is the question. So what's we talk about provoked and unprovoked DVT in general? We tend to say we are trying to prevent post-thrombotic syndrome, which the incidence between 25 and 50%. It's a very wide incidence. And since we started doing research on venous many years ago, and Marzouk is sitting here from Kuwait, we were focusing on post-thrombotic syndrome mostly. Let's look at how frequent phlebitic or thrombotic syndrome. The 1 year in one study, 17.3%, and another study, 27%. So there is a large variation. The 5 years in one study, 28%, in another study, 47%. So why we don't agree on the post-thrombotic syndrome, and a little bit was touched by Dr. Mossad about this subject. These are the clinical features that were adopted by the Cavent study for post-thrombotic syndrome, the symptoms and the signs. So a large number of those are subjective. So, and we see that in the clinic when you tell the patient, do you have pain? No, I don't have pain. Then you tell them use the stocking. Next time he comes, oh, I had pain, I didn't know that until I used the stocking. So a lot of those are subjective. I mean, the patient, it depends how he answered many of the scoring systems we are using. The other ones are the objectives that are measurable. And these are the ones actually like a venous ulcer, skin color changes, or some veins here and there. And they represent some features of post-thrombotic syndrome. The end point in general is to prevent post-thrombotic syndrome, to prevent venous ulcers down the road. And we use for that different studies. We use the CEIB classification and the scoring system. These are the treatment modalities, and we are not going to go through all of them. I'm going to focus on the intervention other than surgery, because honestly, I'm mentioning surgery to say it has no role now. There is no role for surgery anymore. It's done. So whoever thinks it has because in 5 minutes you can put a catheter in the common femoral vein and suction the clot and you get rid of the distension until you find out what to do with the patient. So all depends, is it acute or chronic? We think sometimes the vein has acute DVT, but when we go inside, it's chronic really, and vice versa. All depends where is the DVT, because not all DVTs have to be treated. And we know that only 1/3 of the cases are proximal, which is a problem, and these are the ones we are focusing on. So it depends on most studies, randomized studies, meta-analysis. The randomized studies, actually 3 main ones, and they don't agree on anything almost. All of them, we will find out they agree, we don't have a proof post-thrombotic is decreased. Routine use of the clot is not supported by any of the studies. But we need to know that in some parts of the world called the United States, they remove the clot from the femoropopliteal vein. You know why? Because of the implicit bias to make money. And that will never go away. Even I'm sometimes get the fault of doing that. And you need the good access for that, you need a good ultrasound, you need really to have a good system, you have too many of things to use. And if we look at the KEVIN study, the open label randomized study, iliofemoral patency after 6 months was higher in the catheter-directed lysis than the medical. And the PTS by Villalta score 24 months was lower again in the catheter-directed lysis. And this is one of the few studies, but it achieved a very only 0.047. And it was a very large number of patients that were at the end looked at 209 out of the many they looked at. And these are the changes. So there was some changes in the post-thrombotic syndrome, improving in the KEVIN studies. And bleeding was in 20 patients, so there was some complication. Prevent one PTS in every 7 catheter-directed lysis patient. So if you look at the cost, is it worth it? And we don't know at 1 year, 2 years, is it going to last after that? So the KEVIN study, there is a 14.4 risk reduction, and there's some improvement, especially in extensive DVT. And the ultrasound was used to identify, but we ignored the pelvic veins. The ATTRACT study, even I'm going to skip those to show you in the ATTRACT study. Look at the numbers. They looked at 11,000 or 28,000 patients, and they managed to find a very small number. So if you are going to exclude almost 10,000 patients to treat 1,000 patients, what type of treatment is this you are achieving? It doesn't mean it's not working. You mean very selective in those patients whom you are going to use. And there was some changes, but it was not. The summary of the ATTRACT study, proximal DVT might help, and symptom relief might help. PTS, it did not achieve much improvement in the PTS, and it depended on the quality of life. And they use, again, the catheter lysis. They did not use other methods such Inari or Penumbra on those cases. Yesterday, we touched a little bit on this, that we have a large number of reasons for DVT. Which one of them are we treating? These are all things that we need to investigate as scientists to see why DVT is happening. So which one we are really qualifying or selecting and ignoring all the other reasons? This is the problem with DVT. So the biological reasons are major. CAVA study came, again, similar results. Of course, intravenous DVT is out. Catheter-directed lysis might have a role, but nowadays it's not the thrombolysis that is important. It's what we are using with Inari and other methods. That to remove of the clot, which is much better because you don't have an ICU stay. I'm going to go to the last part. This is actually one of the studies in which look at meta-analysis. It came to the same result. We don't have a proof actually PTS in the long term is helpful with that. We have one of our studies that we looked, this is back to the clot retriever study, which is Inari. The best thing about the Inari study, it says actually you get rid of the clot, less bleeding, no bleeding, but there was no follow. It is a registry. It's not a randomized study. There are 2 randomized studies now running in the United States, and in general, some improvement, but we don't have a proof that post-thrombotic syndrome is one of the material. We looked at ourselves in one of the studies at all modalities, which one is better, and we found actually, this is our study, there's no difference between lysis, catheter lysis, angiojet, Terelis. All of them do the same if the patient has acute DVT. If the patient has chronic DVT, nothing works in those cases. So immediate symptoms might improve, short term might be there. Proximal DVT, there is evidence. PTS, we don't have evidence. Objective measures only. Preserving the valve, we don't know what's the definition, how to preserve the valve. Duration of symptoms is very important. How do we measure actually PTS? We don't have a measure. Long-term symptoms, how long is long-term? We know PTS, the longer you follow, the more PTS and ulcers can form. It is why association like ASH, which is a hematology organization, says you should not do it unless there is a good reason. So honestly, we don't have an evidence that PTS is prevented, but we have evidence symptoms are improved. That's why we have to choose the symptoms based on that. Thank you.